Hi, I'm Frank Diamond, the managing editor of Infection Control Today, where we're trying to give infection preventionists and other healthcare professionals the information they need to battle COVID-19. One of the ways we're doing that is by talking to experts in the field of infection control and prevention and antibiotic stewardship. Which brings me to my next guest, Dr. Yi Guo. Dr. Guo is one of the newest members of Infection Control Today's editorial advisory board, and she brings a wealth of experience. Dr. Guo is the co-director of the Antibiotic Stewardship Program at Montefiore Medical Center, Albert Einstein College of Medicine in the Bronx. She's also an assistant clinical professor of medicine at Albert Einstein. She's widely published and has been practicing as an antibiotic stewardship and infectious diseases pharmacist for more than 10 years. Dr. Guo, thanks for being with us today.
Hi, Frank. Thank you for having me here today.
Let's dive right in. What role did antibiotic stewardship programs play in the COVID crisis?
So that's a very great question. So normally we think that antibiotic stewardship program dealing with just antibiotics, but in this case, we also taking care of antivirals, treatments for COVID-19, for example, the remdesivir, and along with other possible treatments.
So were other healthcare acquired infections, how were they handled during the COVID? Were they sort of pushed aside, or how are they handled during the COVID crisis? Because at one point the hospitals were so filled with COVID patients, and you're right in the epicenter of it.
Yes, so we have a lot of COVID-19 patients. Our hospital so far has been discharged more than 5,000 patients along the Montefiore healthcare system. So in addition to taking care of, as we know that COVID-19 is a viral, it's a SARS-CoV-2 virus. So on top of this viral infection, our patient can also develop bacterial infection on top of that. So many of our patients are not only on antivirals for this treat COVID-19, also on a lot of different type of antibiotics. And these patients tend to develop different infection because there are many different risk factors. For example, prolonged hospital stay, and sometimes patient is on steroids, and also patient is on broad spectrum antibiotics. So hopefully we won't see a lot of resistant bacteria, but that's definitely one of the key games that we are trying to prevent patients to develop more resistant bacteria during a hospital stay.
When a patient developed a bacterial infection, was there a common one that a COVID-19 patient would develop, or were they all over the map?
And so far, we see average bacteria that we frequently dealing with, such as Staph aureus, or some of the gram-negative organisms like E. coli or Klebsiella. So we do see these common infections that play in the game. We see bloodstream infection, and we also see pneumonia, bacterial pneumonia on top of COVID-19. And sometimes, occasionally, we do see a very resistant bacteria that we normally won't see, rarely see. So we have to take them all into consideration when we take care of these type of patients.
Candida aureus you mentioned. Now that was before COVID-19 came along. I know the CDC put it on its list of urgent problems. So it's still an urgent problem. How were you able to deal with that and at the same time deal with COVID patients?
So for Staph aureus, that bacteria we sometimes call it as a sticky organism, and it can cause a different infection. Let's say if it get into the blood, patient can have endocarditis if we don't treat appropriately, and the bacteria can seed in different locations, and if it get to the bone, it can cause bone infection. If it get to the joint, it has joint infection, or heart, you have heart infection. So we take that very seriously, and we want to make sure the patient receives the appropriate antibiotic with the right dose and the right duration to make sure we eradicate the bacteria. And on top of Staph aureus or other gram-negative organisms, we also see like fungal infection because patients have different catheters and different lines in place. So that's another thing that we watch out for.
What was a typical day like for you during the spike? I mean, I'm assuming it's settled down a little bit, right?
Yeah, the volume of COVID patient day-to-day admission has been going down, but we never know, there might be a second surge if we don't practice social distance, or if we don't be careful enough. But we still do see patients being admitted with COVID-19. So on day-to-day basis, we evaluate, like, let's say how many patients we have for COVID patient, how many patients we have in the how many patients we have for COVID patients in the hospital from day to day. We have different calls. We have infectious disease daily call. We have pharmacy daily call. Try to assess the volume, try to assess our manpower, try to see what we can do taking care of the patient. And a lot of time, like our hospital regular floor converted to ICU floor, so we can accommodate more patients because many of them need to be on ventilator. And we assess how much medication we have in hand in terms of like antibiotics, in terms of analgesic, anesthesia. So it's like a lot playing to one factor, just take care of one patient. So we look at the patient volume, we look at what antibiotics patient is on, we make sure patient are appropriate antibiotic, dose appropriately for renal function, and based on the susceptibility, we also de-escalate antibiotic to treat the patient appropriately. We also evaluate who are the candidates for clinical trials for COVID-19, because my hospital also have different clinical trials going on. So we kind of helping with the screening of patient. As you probably heard about this drug remdesivir, which Dr. Fauci has been talking about a few weeks ago on CNN. So FDA also approved the emergency use of remdesivir just a week ago. So many hospitals received remdesivir. So we need to figure out who are the patients will be appropriate for treatment to get the most benefit from. So we establish guidelines and to monitor the patient. And we also have to do a lot of bookkeeping for each patient based on FDA requirement to keep tracking the lot number and make sure the proper appropriate process are in place.
COVID-19 as fundamentally altering how antibiotic stewardship programs proceed in the future, or will it be basically the same method of operation?
The principle is still the same in terms of we monitor the patient, make sure patient is on appropriate antibiotic. A lot of time, initially, we might not know what the patient has. We might start with a broad spectrum antibiotic, but as soon as we have more data coming back, the lab result coming back, the culture result coming back, we're able to de-escalate the patient, de-escalate the antibiotic for the patient to make sure that it's not overkill for the bacteria. So I think one thing that we learned is that we work closely with the infection control preventionist, because when we discover the patient have a very resistant, multi-drug resistant bacteria, we want to make sure the appropriate isolation policy is in place, so we will not infect the patient next door or have our healthcare provider carry the bacteria to the next door patient. So that's something we always work very closely with infection control. And with this COVID-19 is even more important because everyone has to wear PEE, personal protective equipment to go into the patient's room, to take care of the patient, and just to protect the patient, protect our healthcare worker, protect each other, our family member. So we wanted to make sure that we don't bring virus to others who can be risk of having an infection as well. So we work with infection control very, very closely on that. When we see there's a resistant bacteria, we will let our infection control team be aware so they can implement what they need to do for the patient and for the healthcare workers.
Did you have like daily huddles with your infection control, your infection preventionists?
Yeah, so we have a big infectious disease call daily. So that including our infection control preventionist, including our clinical trial principal investigators, including pharmacists, including laboratory folks, because we need to test for the COVID-19, the virus as well, by using different tests. So it's a team approach, multidisciplinary team approach. Sometimes patient can have super infection on top of viral infection. For example, for flu, right? So for patients who have flu, sometimes we see Staph aureus super infection on top of that. For COVID-19 SARS-CoV-2 virus, we're still in the process of evaluating, is this virus also associated with a particular pathogen, bacterial pathogen, can cause super infection. So that data is still under evaluation, but just from what we observed, just by staying in the hospital on broad spectrum antibiotic, with different catheters, urinary catheter or line catheter for patient to receive intravenous medication. These are risk factor for patient to develop infection, a bacterial infection in the hospital. So even without COVID-19, this can happen. So now on top of COVID-19, we continue to make sure that we monitor the patient and evaluate the patient on a daily basis to make sure that to prevent patient acquire infection in the hospital, but if the patient developed bacterial infection, then we have to make sure patient is treated appropriately.
So you were called in, you and your team were called in, I guess, to the very complicated cases, because the people would not only have COVID-19, but they'd have some kind of infection as well.
Mm-hmm.
And during the spike, how many hours a day were you working? Were you pulling 16-hour day shifts or what?
So that we have different people working on different shifts. So almost all our ID attending are on service at this moment during the peak period of COVID-19, and even now we have multiple ID team taking care of patients, seeing COVID-19 patients. And from pharmacist perspective, yes, we working. There's weekends that we still on call for taking care of the patient, and we work around with different shifts to make sure the pharmacy is running, providing the best of care for all our patients with COVID-19 or without COVID-19. Any patient who admitted to the hospital is our responsibility. So definitely everyone is stretched thin, and we work. We do the best we can to take care of these patients. It means that we even work. Means that we work overtime. Means that we work over the weekend. But that's what we should do when we become a healthcare provider. Yes.
You're in the epicenter. Any final words of advice for infection preventionists out there who's wondering what you went through and how you got through it?
I think one lesson we learned is that definitely you need to work with your antibiotic stewardship team member, and usually it's composed of ID physician and ID pharmacist, because they are your best ally. They can provide you a lot of information, and they can also help you manage patient appropriately. They are very knowledgeable in terms of what antibiotic to give to what patient for what infection. So they are a great resource for infection preventionists. And same thing, I work very closely with them as well. And also microbiologist is our best friend. So it's definitely a team approach that can help us to provide the best of care for our patient. And also just for the general public, I think we definitely need to continue to practice social distance. That's very, very important by staying at home, washing your hands, don't touch your face. These can help us to taking care of the patient, taking care of yourself first, to prevent more transmission of the disease.
Dr. Yi Kuo, it's wonderful that you work so closely with infection preventionists and have such respect for infection preventionists. And welcome to Infection Control Today's editorial advisory board. And thank you for joining us today.
Welcome. Thank you for inviting me.